So good afternoon. Thank you so much. And thanks for coming in large numbers to go through the scientific program. Of course, this talk of mine is going to be an industry-sponsored program. It is going to be on a molecule. A request to the chairpersons. So Dr. Shekhar and Sada, if you can just give me 5 minutes of extra time, we can prune on the question answer that I'm allotted to for 10 minutes. So extra 5 minutes with your permission. Thank you so much. I think even in the case discussion we had, I think we had a lot of discussion about the SGLT2 inhibitors. Some of us are justifiably biased towards the positioning of these molecules right from the beginning of the disease. It all started with the EMPERAG outcome. In fact, to be very frank with you, when the EMPERAG outcome results were there and we were all cascading it down and then discussing it among ourselves before the results were there, we were slightly apprehensive about this class of molecules, SGLT2 inhibitors in the Indian scenario. Say a molecule which is going to promote glycosuria, because glycosuria is always viewed as a villain in the context of diabetes. To promote glycosuria, have some metabolic benefits, it was something which we didn't anticipate, but fortunately, we were all pleasantly surprised when the results came. And the EMPERAG outcome tested empagliflozin compared to placebo on top of standard of care for non-inferiority with respect to the MACE. That is, non-fatal MI, non-fatal stroke, and CV death. It was found to be non-inferior, statistically significant. Subsequently, it was tested for superiority. It was found to be positive. So, a trial which was very, what shall you say, tentative, non-inferiority being to be proved, subsequently it was superior. So, SGLT2 inhibitor, EMPA was the first molecule to subsequent analysis showed that empagliflozin also had the benefit of hospitalization for heart failure and also the renal benefits. So, in this background, I think the trial of dapagliflozin, the DECLARE came. Now, in clinical practice, we witness as we go through the journey of a diabetic patient, a lot of comorbid conditions getting added. Some of them are linked to each other, as you will see here. For example, the CKD and the heart failure. Just to give an example, somebody has heart failure, there is hypertension, there is hypoperfusion, the kidney reacts. RAS mechanism is stimulated. Somebody has got, say, for example, acute kidney injury or anemia because of that, that has an impact on the cardiac function. So, the manifestations of the disease, when it comes to the endpoints, some of them are linked to each other, and look at the burden of these two disease entities in the Indian context. I think our knowledge about the complications of diabetes mellitus have been rather streamlined, I would say, if you can use that word, after the advent of these molecules, because we started learning more from the literature what we probably neglected to learn before this, because there are no specific molecules to address them from the first point of view. So, when you talk about heart failure, we always had a belief that it could follow an occult or a documented coronary event. In fact, we know about the entity of diabetic cardiomyopathy, but heart failure occurring as the first manifestation of the cardiovascular disease in the diabetic population, I think we got that message from the literature. And more importantly, it is not only the early manifestation of diabetes mellitus, but also this is associated with enhanced mortality. So, there is a complication of diabetes called heart failure. All of us are aware of it. In the temporal sequence of the complications, it can occur very early, and it can be associated with survival, chances of survival are poor, as depicted by this data. That is with respect to heart failure. What about the CKD? From the STENO2 trial, which I have tabulated on the left, we have learned that clinicians have to move away from the glucocentric approach to the multicentric approach to have a tangible effect on the complications, which we are meeting with success. Now, control the sugar, control the hypertension, control the dyslipidemia, the body weight, cessation of smoking, etc., whatever you want to do, still there is a huge residual risk with respect to the CKD. So, in the context of these two, maybe I'll just touch upon the metabolic aspects. In the context of these two, progressive CKD, heart failure hospitalization, CV mortality, let us look at the evidences. Some of them have been deduced, initially viewed as a captured secondary endpoint in the some of the trials including dapagliflozin, and some of them were post-hoc analysis, but ultimately the message is so meaningful, so much relevant in the day-to-day practice of diabetes mellitus, which we'll share in the next 10 to 12 minutes. Metabolic benefits, I think all of us are aware of it. Just to start the discussion and then highlight about the magnitude of reduction, which is modest but sustained enough in the various data that are available with us, not only sustained, not only effective, but also durable with respect to the length of benefit that you have compared to a molecule like your sulfonylurea and metformin. So with this brief introduction about the metabolic inputs, just to reconfirm the message or remind ourselves about the messages about the metabolic benefits, let us go on to this wonderful trial. Why I call this wonderful trial is empiric outcome with EMPA was patients with 99% or close to 100% having a previous atherosclerotic cardiovascular disease, high-risk population. DECLARE had about 40% of the subjects, 60% with multiple risk factors. So the population represented, the population that has been there recruited in the DECLARE is more or less reflective of the patient population that you and I see in the clinical practice. It's not the pure patients with end-stage problems that we do see an admixture. So these results become a lot of relevant to it. And look at the patient population with respect to the kidney, one of the metrics of the kidney disease, A1, A2, A3, the level of albumin creatinine ratio. And what you did have, here there's a difference I want you to focus. In empiric outcome, it was the 3-point primary MACE, which was tested for inferiority and also superiority, and subsequently the renal as well as heart failure endpoints were exploratory. Whereas here, probably because of the inputs given by the empiric outcome and the people who conducted the trial were cognizant of the fact that we are having a less risk population, the primary endpoint was it was divided as a primary safety endpoint of MACE and a co-primary efficacy endpoint of CV death and heart failure hospitalization, which was found to be superior. That's why when you say DAPA was the first drug to document, in science, in essence, what it means is it was pre-planned to capture these two endpoints as a co-primary efficacy endpoint, and also the renal endpoints were secondary endpoints which were predefined. As you will see, whatever it is, a 50% reduction or a 40% reduction, allowing the patient to go in for CKD of 3A or 3B or beyond that, and also having an effect on renal. So, DECLARE was the first trial to document and reaffirm the exploratory findings of empagliflozin in the empiric outcome in a study capturing it as a co-primary efficacy endpoint, and then the renal specific endpoints were there. So this confirms. Now, the cardiorenal benefits, just to visit again, and of course the comparison has been made, which I've already told you how it has been there. So largest, longest, and broadest. When we talk about the cardiorenal disease, you start with a patient, a diabetic with multiple risk factors. There is onset of atherosclerosis, and probably with some extra efforts, you can document subclinical atherosclerosis. Then it progresses, you have an event. You have the metabolic perturbations affecting the function of the tissues, including the heart. You have the heart failure with preserved ejection fraction, overt heart failure, and then the risk of mortality. You start with varying degrees of albuminuria and gradual decline in the renal function. In other words, the temporal sequence of events gives us opportunity to appreciate the natural course of events. Unfortunately, we have got molecules to arrest. That's why we are calling this, as Nalabramal nicely alluded to in his presentation yesterday, disease modifying. So far, after Steno 2 data, we have been tuned to the concept of multifactorial intervention. Here, we are able to offer something much, much more. So you have the opportunity. In fact, the extrapolation of the credence data tells you that with proper intervention, maybe one can postpone even the necessity for renal replacement therapy by about 12 to 15 years. And at this point of time, it's an amazing intervention, an amazing message for the clinicians. Emboldened by the data of the DECLARE with respect to the renal endpoints, this was a dedicated DAPA-CKD study wherein subjects with and without diabetes were recruited. And look at the other aspects. The recruitment eGFR was 25. Now, when these class of molecules were introduced, we always had an apprehension whether with the reduced renal function, we'll have the recommendation or the cushion to use these molecules, will they be beneficial? On the other hand, if you see, they are much more beneficial in patients who have got advanced renal disease rather than milder forms of albuminuria CKD. Even there, they are beneficial as captured by the declare. So here you have a broad range of the recruitment eGFR was 25 and other data are there. So in a dedicated kidney disease, DAPA-CKD, with a good number of subjects, look at the endpoints. The endpoints were, the primary outcome was, again, a reduction in the estimated eGFR of more than 50%, ESCKD, etc., which were significant. But again, being influenced probably by the EMPA-REG outcome, they had the vision to include the all-cause mortality and the composite of CV death and heart failure as a predefined secondary endpoint. What I am trying to say is these were anticipated and proved positive so that in a DAPA-CKD trial with hardcore endpoints being satisfied to the maximum, other endpoints with respect to CV death and all-cause mortality were also captured in this particular study, and this was regardless of the diabetic status, non-diabetic, diabetic, as well as pre-diabetic stages. So that is why you see the various organizations promoting the guidelines, giving some sort of a clarity which incorporates the messages emanating out of these trials for a meaningful translation and clear-cut guidance to the clinicians in the day-to-day practice. Maybe in another 5 to 7 minutes I'll finish. So this is with respect to heart failure. Again, emboldened by the response and the co-primary efficacy endpoint of CV death and heart failure hospitalization in the DECLARE. This is a dedicated study with patients with heart failure. The average LV ejection fraction was 31. You have the NT-proBNP value, and more than 50% of subjects did not have diabetes. So this molecule's performance in the sphere of heart failure hospitalization, mortality, as well as CKD has impressed the industry throughout and the clinicians throughout the world to design such a trial wherein the benefit is not only restricted to the diabetic population, also to the non-diabetic population. Look at it, the primary endpoint in this heart failure, which was again CV death and heart failure hospitalization, was significant, and extrapolation of the data, that is, when you have these two curves, events start happening from day one. So the point at which it becomes significant, if you're going to calculate, I think Ramchandran is there, is an exponent in statistics. So whatever I've learned from you, I'm trying to pass on to my friends here. It is as early as 28 days. This is exploratory. This is subsequent analysis, but the message is very clear, and you need to treat 21 patients for less than 2 years to reap this benefit as early as 28 days with respect to CV death and heart failure hospitalization. What about the entity of preserved ejection fraction? So look at it. I think the recruitment, again, similar to the previous one, non-diabetics being recruited, comorbids have been totaled, and look at the range of ejection fraction. You have patients who have the mid-range ejection fraction, 41 to 49, 50 to 59, and more than 60, and the molecules on board, and there are some people who did have a previous heart failure also. Again, in this study with preserved ejection fraction, which was called as DELIVER, dapagliflozin influenced the primary endpoints to the tune of about, see, the benefit was 18%. You could see the benefit as early as 13 days. So previously, in ejection fraction being reduced overt for heart failure patients, it was 28 days. In patients with preserved ejection fraction, as early as 13 days. And if you look at, again, this was, I think, brilliant idea by AstraZeneca, because they pre-specified that because the data available with DAPA-HF and DELIVER is so much, the number is so huge, so they decided to combine the data to look at the outcomes. So this was again pre-specified with respect to these metrics, CV death, all-cause death, etc. Let us see. CV death and all-cause death, yes, which we originally saw with respect to the EMPA-REG outcome as one of the primary endpoints of MACE. Here it's being, and also the heart failure, total heart failure as to the first heart failure, and of course the MACE. So Prompted by the evidences, I think it is not surprising that the European Society of Cardiology included this in the management, and then probably after the standard therapy, which the cardiologists are used to as evidence has gone by the guidelines to them. Now look at the patient's mid-range as well as preserved ejection fraction. DAPA is there very, very early. Very, very early. I think it's worthwhile patronizing these molecules very early in the course of the disease for the metabolic benefits, anticipating the complication, natural history of the type 2 diabetes mellitus, and having a meaningful impact even once they develop these manifestations. So heart failure, preserved ejection fraction, SGLT2, and then as and when demanded by the clinical situation, you have the other, other molecules on board. SGLT2 inhibitors influence the excretion or the uric acid transporters so that there is serum uric acid being down. This has been documented. This is one extra glycemic benefit that we see. And this is an interesting data. I wouldn't go into the greater details. Dementia. In a data capture wherein they were able to identify and study patients before and after exposure, exposure to SGLT2 was associated with a favorable effect on dementia, and so also with retinopathy. A theoretical speculation. So when you talk about compare the kidney and the retina, I think the podocytes in the kidney and the pericytes, they are probably parallel. And podocytes and the insulin resistance in the podocytes is associated with increasing proteinuria that can be impacted by the SGLT2. Some of the mechanistic and experimental data give evidence to this. I'm speculating. Maybe a similar mechanism in the pericytes, probably. Absolute speculation. So the polycystic syndrome, I think Samit is there in the other room. For any other doubts, you can ask him. Metabolic benefits in patients with PCOD. And the redistribution, we have been talking about the ectopic fat deposition in the pancreas, the liver, and also in the visceral adiposity. Now the visceral adiposity is also viewed as an ectopic extra deposition of fat. Had the patients had the genetic makeup or whatever advantage they have, even the extra calories could be accommodated in the subcutaneous fat. Why in the visceral fat? I think that's a food for thought and pondering. So pancreatic and liver fat extraction impacted by this. And also, there are data, small in number, various stages of NASH and including fibrotic stage, favorably impacted by the SGLT2 inhibitors. So cardiac, renal, and metabolic, yes, probably. I think this being an industry-sponsored talk, they would like to highlight and the aspects of DAPA with respect to the other molecules. Yes, new answer to. When you had a lot of non-diabetics in the DAPA kidney as well as the DAPA HF, you had the opportunity to find out how much of diabetes you can prevent. Yes, both of them prevented. In the case of DAPA, it was. And also, in these studies, the CV mortality as well as the CV death was captured as a predefined secondary endpoint so that it gives an opportunity to compare, at least from the data that is available. In fact, all of us are so comfortable using empagliflozin, the first molecule to have a primary effect on patients with atherosclerotic cardiovascular disease. But these data capture should remind the clinicians, yes, there is yet another molecule, probably as much as performing as much compared to the molecule which was introduced earlier. Now, again, whatever I've discussed with you in the last 10 to 12 minutes and the extra time gracefully given by the chairpersons did emerge out of the drug being tested by the innovator. Now in clinical practice, we owe a moral obligation to the society. We do have a compelling necessity to translate science to a huge chunk of population. All of us understand that the innovator drugs are expensive, the generics are cheaper. But the data that is generated, which gives us the importance to listen and then participate in the good meet and to talk with so much of confidence, is by the drug. So then you may turn around and ask me, do you think we should not patronize generics? Absolutely none. We have to. And of course, in I think Indian context, it is a branded generic, if I could say so. So the branded generics certainly are able to enable the clinicians to pass on the benefits of the science to a huge chunk of the population. But in situations wherein you can respect the knowledge that has accrued out of this molecule, I think the innovator deserves a share, which is your discretion. It could be retaining some of the patients rather than switch over. It could be even initiation, leave it to you. But I feel there is always, not only for DAPA, for any innovator going off patent, I think 100% switchover probably will be some sort of an injustice to the innovator molecule. This might dilute the interest in the research and then translating that research to our Indian population. That's my, I'm sure Manoj and Professor Ram and Professor Ekidas and Sundaram are there. They might second or they may not have other views. And of course, there could be some differences. I mean, this could be secondary. In my own perception, I would give importance for this with some amount of patronization still being retained or given to the innovator drug. So I'll just finish another couple of minutes. So there could be, whenever there's a generic, we have seen in clinical medicine situations wherein the efficacy has been compromised, even in the oral space. So, ladies and gentlemen, in this presentation, I've been asked to detail to you about the new insights of DAPA. The new insights are reaffirm whatever we learned from the DECLARE. That is, it is effective in CV death and heart failure hospitalization. Dedicated trials in patients with CKD, heart failure, and even heart failure with preserved ejection fraction have sent a lot of positive signals confirming the original observation, and we had other benefits as well in the form of prevention of diabetes as well as the reduction in uric acid. Some of the other things are just, we are beginning to understand, maybe the SGLT2 inhibitors do have a plethora of benefits. We have started looking at some of the other benefits. Thank you so much for the opportunity. Thanks for the
Thank you, sir.
Thank you all.
Excellent.